and Dr. Hansan Banjara ma'am.
Hello. The next lecture is by Dr. Maruti Kalyankar sir on the topic of frontal recess surgery, a predictable approach.
Good afternoon, everybody. President of Raipur Secretary, my friend, good afternoon. Today I am going to present frontal recess surgery, a predictable approach. Well, everybody wants like this post-operative, the well-healed cavity. The impact will have taken frontal surgery is the post-operative image. And for here, I would like to play a small video. The frontal is a 3D space is not enough. This video shows how the frontal sinus or frontal recess looks like on the cadaveric. All about the frontal recess anatomy in the cadaveric bone. Now in this presentation, when we will understand the anatomy of frontal recess, new frontal sinus, frontal recess building block concept, planning of surgery, and access of the technique. Now, these are the images which shows the post-operative nasal cavity. We want this is the ideal post-nasal cavity where it should be well ventilated. There should be a proper drainage and there is a mucosal preservation. All the mucosa of the nose and the sinuses we have to respect and preserve. And the post-operative scan of this patient is like this. The all cells they are removed from the what is the pathology is removed. Then it is about the image of frontal sinuses post-operative slice. This is what the mucosal preservation is. There is no stenosis of the frontal recess. Is all the mucosa of the frontal recess is preserved. Then, endoscopic sinus surgery is all about the surgery of landmark. We know all four lamina. There is the uncinate process, molla ethmonalis, basal lamina, and the sphenoid sinus. In the cadaveric, this image which shows all the laminas. and this is the endoscopic view where the uncinate bulla, lamella and the sphenoid is open. Why the frontal sinus is challenging for the ENT surgeons? Because of its anatomical variations, because there are a variety of frontal cells in the frontal sinus drainage pathway. Technically it is challenging because of difficult angle visualization, and we have to use the curve instrument along with the ankle endoscope. And the anatomical risk we realize that is for injury to the anterior artery, then skull base and the orbit. The location of the frontal races create anxiety among the surgeons because of all these smart cells, that is agar T1, T2 frontal cells. Medially, that is the olfactory fossa, that is the orbit. This is a complex anatomy. So, the main fear is of the anterior isthmoid artery. But if you plan the surgery, if you read the CT scan properly, plan accordingly, and dissect out the sequential dissection of the cells, then you go cell by cell and you avoid the injury to the surrounding structure. The frontal vessel, the frontal vessel is bounded by isthmoid cells, the anti-isthmoid cells, and posterior isthmoid cells. This is the old classification. There is the agar cell, the entire of the frontal cells, then the supraorbital cells. Then the new classification is, that is International Frontal Sinus Anatomical Classification. Here it is a simplified and easily classification. There is the agar cells, supra-agar cells, and the supra-agar frontal cells. These are anterior cells, and the drainage pathway is posterior to that. Whereas the posterior cells is the bulla ethmolis, the suprabullar cells, and the cell which is extending in the frontal recess along the posterior wall of the base skull. With all cells we have to see on the then we have to study the cellular configuration in the frontal recess area. When we open one of the cells in the frontal recess area, again if there is cell posterior to that, we see a lot of openings are there, and there we get the confusion, which is the frontal sinus there. So the frontal recess creates the anxiety among the ENT surgeons. Then for this we have to plan the preoperative patient evaluation, that is understand the anatomy of the patient, and the anatomy of the paranasal sinuses, and study of the computerized CT scan for the cellular configuration and three-dimensional reconstruction of the anatomy is important for the careful preoperative planning and the meticulous and the complete surgical execution. Therefore, the critical for success of the surgical outcome of primary frontal sinuses is important. Then on CT scan, we have to see the transition from the frontal sinus to the frontal recess. This is very important to decide out the cells. Then this CT scan shows big cells which is going in the frontal sinus, and these images that shows how the frontal recess is dissected. All the cells in the frontal recess are dissected. And again, we have to on the CT scan study the skull base and configuration. The Keras classification is there. There is a type 1, type 2, type 3 Keras classification. This is very important to this anatomy is very important when we are dissecting the frontal recess air cells. Then the uncinate process, the position and insertion of the uncinate process is very important to determine the frontal sinus drainage pathway. And understand then the Kuhn's classification is the old classification where there are cells in the frontal ethmoid cells, there are agar cells, then supraorbital cells and the frontal ethmoid cells, type 1, type 2, type 3, type 4 cells are there. Then you have to study this on the CT scan, plan the surgery accordingly, and on table execute the procedure. Then while using the endoscope, when we are using the 0-degree endoscope, our instruments they are below the 0-degree endoscope. This is very important where we are dissecting the frontal recess particularly, because there we have to use the 70-degree endoscope, and in that stage you have to have an instrument above the endoscope so that it is easy to maneuver the instrument. We can visualize the things and we can dissect out the cells. Right? This is a simple configuration. This is the agar cell. It is uncapping of the L. Only agar cell is there. The images shows the dissection of the agar cell. And once you remove this extra wall of the agar cell, directly you are visualizing the frontal sinus. This is the frontal sinus flow. Then this video shows the uncapping of the eggs, where in the left nostril, by ball probe, I am palpating the posterior wall of agar cells, and without injuring the surrounding mucosa with the ball probe or with the J curate, I am outstretching the cells. I am going posterior to that lamina and I am dissecting that lamina. And after outstretching this lamina, then the rest of the thin bone and the mucosa that we can divide out. This is the uncapping of the egg. Only a single agar cell is there. Whereas in this case, this is a case of polyposis. In this patient, there are 2 cells above the agar lazy. Anna? So this is the agar cell. The one more cell behind this one, and as I said earlier, I am going back to the cell. Like this, identify the cells, go behind that cells, come from posterior to anteriorly, remove the lamina, remove the thin bone, remove the mucosa with the divider, and you open the big axilla over there. The agar cell is being dissected. Here, after removal of the agar cell, this agar cell posterior wall. Again, posterior wall is being removed. This is the opening again, and this is the bit-traded pathway of the frontal sinus. Like this, we have to understand the anatomy or the anatomic configuration of the cells and dissect cell by cell. Sequential opening of the cell is very important. So the plan of the surgery is understand the cellular configuration, open the cell sequence, and look from the frontal sinus drainage pathway. This is the supraorbital frontal cell. You can see it's a big cell over here. It's the big cell. This is on the right side. See, you can see there is a very small frontal sinus drainage pathway. It's a big cell over there. Even this much small frontal sinus pathway, if you don't injure the mucosa around the opening, then that will heal very well and that remains patent. On the other side also, you can see it's a very small, there is very small frontal sinus drainage pathway. If you open that cell, carefully, if you remove this lamina, and you can enter in the frontal recess, frontal sinus. Then frontal sinus drainage pathway. See here, you can see this is the other cell, the one more cell over there, and this is my probe is going in the frontal sinus drainage pathway. Likewise, we have to identify the frontal sinus drainage pathway, remove the cells anteriorly, and open the frontal sinus drainage pathway. The limitation of the adult cells, frontal cells, or the supraorbital cells, as they are blown out, that narrows the frontal sinus drainage pathway. Bulla wise, most of the time we do the intact bulla technique from the frontal recess approach. Usually bulla protect the anterethmoid artery. See on this side, see, after removal of this bulla, you can see this anterethmoid artery is well protected behind that. The injury of the anterethmoid artery here. This is a orbitocranial canal. Sometimes it is hanging in the promontory, in the nasal cavity, but most of the time there is a thin canal over the anterofacial anterethmoid artery. Even in the severe mucosal disease, the polyposis, or in the extensive disease like this, there is the importance of the decongestion of the nasal mucosa. We use patty, or we use the Merosil, which is soaked in saline and adrenaline, and that gives the good decongestion. And by keeping the repeated patty in that area and getting the clear field, we can dissect out even there is extensive mucosal disease also. Then these are the few surgical videos I want to show. Is the axillary flap technique. The advantage of axillary flap technique is we raise the flap in this axilla. We can use the straight endoscope instead of using angle endoscope, and visualization is easy with the 0-degree endoscope. This is technique popularized by the PJ Ormond. So I am not able to do the fast forward thing, that we have to see the video as a whole. Now this is the incision, almost 1 centimeter above the axilla on the lateral wall. Elevate this flap on the middle turbinate. When there is a limited disease, this patient had a single fully isolated frontal sinus disease, then that's why I tried the axillary flap technique. Remove the bone, remove the axillary bone with the Clarison punch, or you can use the drill over here. Divide out the mucosa, or agar cells, you can divide out like this. Intermittently pour the Merosil for a decongestion mucosa, and then you can even set out the cell beyond that agar cell. You can see the frontal sinus like this. Now next one is the Carol's window. This technique is popularized by Richard Hunway. Here the incision is are above the axilla, and anteriorly on the lateral wall also the incision is quite anteriorly. This is somewhat a robust flap. You can peel out the axilla, or you can go quite above with this incision. We have to do the axillectomy. This provides better visualization with a 0-degree endoscope, and this makes the frontal recess surgery very simplified for removal of the bone in that area. So the interpostal diameter, if it is small, then you can fill out the quite significant amount of the bone over there, and you can enter in the frontal recess. This is the small video. This patient had a frontal disease, isolated frontal disease. Then this where the left nostril is the middle turbinate. The incision is quite above over up here. As I want to do a very minimal surgery in the frontal recess because it's a single cell is involved in the disease one. I have taken this very small incision. That is the elevation of the flap. This is the inferior base flap. Now reset out the flap, put inferiorly. Now you can see the this is the bone, ascending process of the frontal fossa. This is the axillary bone. Now you can drill out this bone. You can use Kerrison punch or you can drill this bone. Now you can see the agar cell. Here is the pullite list, and this is the cleavage we want to dissect out. With a ball probe, I am just assessing the structure over there without injuring the mucosa. I am just out fracturing the lamella over there. See, this is the frontal sinus drainage pathway. The frontal sinus drainage pathway. With a J curate, I am out fracturing that lamella. And again, I am removing the bone from the lamina. This is the separation of the mucosa over there, and with the divider, we can divide out the thin bony chips and the mucosa. See that we should not injure the circumferential area of the frontal recess. This one. It's about the Calvin's window. And another is again a supra-agar frontal cell. We have big cell over here. Again, this patient had a parasite turbinate, the anterior vegetation of the anterior turbinate there. This is the ancillate, this is the axilla. I have to go quite higher up in the axilla over here to set out that bone and that cell. See, this is the axilla. I am doing maxillary widening. This can be done with either Kerrison punch again, or you can dig out over here. I am using the Merosil. Now this is the cell of our interest. Now I am putting the ball probe behind that lamina. See, I am palpating. I am not injuring the mucosa over here. This is the probe in the drainage pathway. I am out fracturing that lamina. See, the bone is being separated from the mucosa. I will remove that bone chip and then remove the mucosa with a divider so that there will be less mucosal injury. See, this is a dissection of that lamella, the ball probe. Now this is the frontal. Now we can deal out some anterior spine area to widen up the drainage pathway. Here if you see, this is the frontal. This is the mixed-in mucosa. You can divide this mucosa and have a wide frontal recess opening. And as I said, these are thick secretions in the frontal sinus. And you wash. as I said, bulla always protects the anterethmoid artery. See, I am just removing this bulla, interface of the bulla, I am just dissecting out with the J curate, and below you can see the anterethmoid artery. This is how this supraagar frontal seal is removed by widening of the axilla. Now, how to confirm whether we are in the frontal recess or not? Put a ball probe from over here. Just see that ball probe is smoothly going away, up above, and even you can confirm with the endoscope. You can confirm this way, and you can confirm with the putting the endoscope below, and the probe, this ball probe is going to the frontal recess. Now, how to confirm again the frontal recess opening? That is a translation test. The factors that affect the difficulty in frontal recess, these are the excessive disease in the frontal sinus, or the resected pleural turbinate, and the patient with a few operative landmarks. Then the previous surgery, or the scarring of the frontal sinus. Then the narrow versus the wide anteroposterior diameter of the ostium. Then the frontal cell type 3 type 4 cells which is obstructing frontal ostium. And the narrow bone, the new bone formation in the region of frontal recess. These are some difficult situations in the front sinus. But still, by identifying the anatomical landmark, we can dissect out the cells in that region, and we can open the frontal sinus. Now, to conclude talk, the conclusion that the careful examination of the anatomy more in one plane, then plan the least invasive approach. Positive identification of the frontal sinus with a ball probe, then identification of the anterethmoid artery, and positive identification of the skull base, preservation of the mucosa is must, and keep sinuses, all sinuses open the post-operative period. Thank you. This is one of the post-operative video of the frontal recess. Pretty understood. Thank you.
Very nice presentation, sir. House is open for question answer.
Maruti,
Sir.
First of all, congratulations. Excellent video. So, which recording system are you using?
These are basically these are videos from Sony recorder. Initially with that, and now I am using the IDA. Okay, it starts with that.
Do you have
And the
Spice?
starts no, it is three chip HD starts.
HD. Image one hub.
Image one.
One common question is open to all. I'm having a lot of problems with lateralization of middle turbinate after. Okay. So what do you do to prevent this? I'm personally having a lot of problems after.
Basically, in this case, I would like to open the axilla more, because where axilla attached to the turbinate, that is the site. Sometimes you get very narrow area. That area. It's always better to open the axilla more, so that it is easy for instrumentation and there is less trauma during the surgery. Because repeatedly we are keeping pushing the endoscope, using the instrument along with that. That is the only thing. Our best way to trim the anterior, the well restriction of the anterior turbinate. That even in post-operative period also, that gives better cleaning of the cavity.
So you cut the anterior part of the middle.
If it is a flappy middle turbinate sort of thing, or it is a sort of lateralized sort, then I can do the wedge restriction of the anterior turbinate.
Do you ever suture the middle turbinate to the surgery?
Not not. Sometimes it is really very effective and costly.
In routine phase for pansinusitis or nasal polyposis, which technique you prefer when you open the frontal sinus? The intact bulla technique or
Basically that thing is that the axilla should be very wide so that instrumentation is easy. Routinely I use 70 degree endoscopy.
no, what I am asking, when you open the frontal sinus in cases of extensive polyposis, you do the intact bulla technique or you remove the ethmoids? Then
So
you do the
preferably intact bulla technique. If I find some difficulty, if they are not going or identifying the cells, it is better to remove the posterior cells, bulla, posterior, but then come back to the anterior.
then come anteriorly.
To open the front, microdebrider, mushroom punch or cobra punch, which one is better?
Of course, the removal of the mucosa surrounding the ostium is the microdebrider, and then the punch is better. But see
Mushroom
that-
punch or cobra punch?
Mushroom punch. But see that we should not circumferentially injure the mucosa of the ostium. Usually the anterior part or lateral part of the ostium can do the binding. If there is a bone, then you can even peel out the bone to get the widen frontal access.
Thank you, sir.
Sir, what are your way of preparation of the patient in routine phase?
Usually prior to surgery 7 days, I routinely use antibiotic and decongestant and omnocortin for 7 days. TID, BD, OD. And for 7 days, I prefer to do that sterile preparation for the mucosa preparation. Then my surgical planning of surgery starts 7 days prior to the surgical day.
What are the decongestion techniques?
Usually, in intraoperatively, I use the Merocil, that soak in the saline and antiline.
And do you prefer J or LA?
Of course, GA.
Thank you, sir. Thank you very much for your nice presentation. Thank you.